Imagine a disease that is so stealthy that for every single person you see paralyzed in a hospital bed, there are literally 200 perfectly healthy-looking people walking around outside.
Right.
And they're completely unaware they are carrying the virus,
Mm-hmm.
multiplying it, and passing it to everyone they touch. It's like this invisible army.
Yeah, it is a terrifying reality to confront, honestly.
I mean, moving silently through a population, leaving absolutely no trace until it suddenly, inexplicably, destroys a child's ability to walk.
You are describing an epidemiological landscape where the visible threat, the paralysis, is really merely the tip of a massive hidden iceberg.
Yeah.
To fight something like that requires a fundamental shift in how we understand disease and, well, human interaction.
Welcome to the deep dive. We are taking the source material, a huge stack of medical literature, historical data, and public health reports, and synthesizing it just for you, the listener.
That's right.
Because if you're joining us, you want to get past the surface level summaries. You want to understand the actual mechanics behind the headlines. Today, we are undertaking a really comprehensive exploration of poliomyelitis. Polio.
So we're going to track this from a microscopic strand of RNA all the way up to a global, multi-billion-dollar eradication campaign.
A campaign that, surprisingly, hinges on the trust of local community leaders.
And we really have to look at this holistically.
I agree.
You know, you cannot understand polio just by looking at a virus under a microscope. It is a study in virology, yes, but it is equally a study in sociology.
And extreme logistics.
Right, and the incredibly fragile nature of global public health infrastructure.
Okay, let's unpack this. Let's get right into the biology of the invader.
Let's do it.
We're looking at a viral infection that is crippling and potentially fatal. But crucially, it is vaccine preventable.
Yes, absolutely.
And because of the global effort to wipe it out, it is a globally notifiable disease.
Which means that the moment a healthcare worker anywhere on Earth even suspects a case of polio, they are legally obligated to report it immediately to international health authorities. I mean, the surveillance network is really that tight.
So what exactly is this thing? The etiology breaks it down. We are dealing with an RNA virus belonging to a family called Picornaviridae.
Yes.
And specifically, it sits within the enterovirus genus. Let's decode that a bit. Pico means very small, and RNA refers to its genetic core.
Let's consider the physical nature of that family for a second. Being an RNA virus, as opposed to a DNA virus, means its genetic material is relatively simple.
Okay.
And being simple makes it prone to rapid replication. And being part of the Picornaviridae family means it is remarkably stripped down.
What do you mean by stripped down?
Well, it does not have a complex lipid envelope surrounding it. It is essentially just a tough protein shell, a capsid.
Just a shell protecting a tiny string of genetic code.
Exactly.
And that lack of a lipid envelope is actually what makes it so dangerous in the environment, right?
That is the core issue, yes.
Because we've talked about other viruses on this show that just fall apart if you wash your hands with basic soap.
Right, because the soap dissolves their fatty outer layer.
But this polio virus doesn't have that vulnerability.
No, it doesn't. Because it lacks that envelope, it is incredibly resilient. It can survive in harsh acidic environments.
Which becomes very important when we talk about how it survives the human stomach.
Precisely. And it can persist for a really long time in contaminated water or sewage.
Which brings us to how it spreads. Because it's an enterovirus entero, relating to the intestines, the transmission pathway is the fecal-oral route.
Yes. The virus replicates in the human gut and is shed in massive quantities in the feces of an infected person.
Oh, wow.
From there, it finds its way into the mouth of another susceptible person.
So for you listening, I want you to picture a hot, humid summer afternoon. You have young kids, and we know this virus primarily targets children under 5.
With an equal male-to-female ratio, I should add.
Right. So they're playing outside, they're playing in the dirt, maybe swimming in a local pond or a community pool.
Sharing toys, putting their hands in their mouths.
Exactly.
Yeah.
All it takes is microscopic amounts of contaminated material on a hand, a toy, or in a sip of water.
And that environmental setup is precisely why, historically and currently, polio transmission peaks during those hot, humid months.
Makes total sense.
The social behavior of children combining with the environmental resilience of the virus creates just the perfect storm for transmission.
Now, the contagiousness of this is what really caught my eye in the sources. It says polio is 100% infective to susceptible individuals. But hold on, I need to understand the math there.
Sure.
If one kid in a household gets it, and it's 100% infective, does every single person in that house who isn't already immune automatically get sick?
The crucial distinction here is the difference between infection and disease.
Okay, lay that out for us.
When virologists say it is 100% infective, they mean that if you are susceptible, meaning you have no antibodies against it, and you ingest the virus, it will successfully establish an infection.
So definitely getting in.
It will enter your cells and it will replicate.
Yeah.
You are infected.
Right.
However, being infected does not mean you will develop the clinical disease of polio.
Okay, so the virus gets in, it sets up shop, but it doesn't always trigger the devastating symptoms.
Exactly.
Which brings us back to the iceberg you mentioned at the very beginning.
Yes, the 200-to-1 ratio. This is the defining epidemiological characteristic of polio.
It's just staggering.
For every single apparent infection where a patient shows clinical symptoms, particularly paralysis, there are 200 inapparent asymptomatic infections.
Meaning 200 people who drank the contaminated water, whose bodies are actively multiplying the virus and shedding it back into the environment,
Yes.
but who feel absolutely nothing. Maybe not even a stomach ache.
None. They are entirely silent vectors.
Wow.
By the time a doctor diagnoses one paralyzed child in a village, the virus has been circulating and multiplying through hundreds of other people for weeks.
It's already everywhere.
It is already deeply entrenched in the population. You are fighting an enemy that is fundamentally invisible until it is too late.
It's using our own bodies as a stealth manufacturing plant. And we aren't just dealing with one single blueprint for this virus, right?
No, we are not. There are 3 distinct serotypes.
Poliovirus type 1, type 2, and type 3.
Yes. They are structurally similar enough to be the same virus, but their surface proteins are different enough that your immune system views them as completely separate invaders.
So if you survive an infection of type 1, you have lifelong immunity to type 1.
That's right.
But type 2 could still easily infect and paralyze you.
Precisely. Which means any successful vaccine must be trivalent, or at least capable of providing protection against all the wild types that are currently circulating.
You have to train the immune system to recognize all 3 disguises.
Exactly.
Okay, so we've established what this virus is. It's a tiny, tough, unenveloped strand of RNA. It spreads through the fecal-oral route, hiding in 200 people for every one person it visibly strikes.
Correct.
But if it goes into the gut, how does it end up destroying a child's ability to walk?
The pathophysiology.
Yes, I want to trace the actual physical journey of this virus through the human body. What is happening?
The journey begins the moment the virus is ingested. It enters the mouth and begins to travel down the gastrointestinal tract.
Okay.
But it doesn't wait to reach the stomach to start its work. It immediately begins replicating in the nasopharynx.
Which is the upper part of the throat behind the nose.
Right, and also in the mucosal lining of the lower gut.
So it establishes a beachhead right away. But it doesn't just stay on the surface of the throat and gut. It pushes deeper.
It does. And this is where the virus exploits a major vulnerability in our own defense systems. It invades the local lymphoid tissue.
Like the tonsils?
Yes, the tonsils in the throat and structures called the Peyer's patches in the intestines.
We need to unpack what Peyer's patches are because that sounds highly specific.
Think of Peyer's patches as localized security checkpoints for your immune system, embedded directly in the lining of your gut. Their entire job is to constantly sample the bacteria and viruses passing through your digestive system, identifying threats, and building an immune response.
So they are packed with immune cells.
Densely packed.
But wait, so the virus intentionally goes to the security checkpoint. That seems like a terrible strategy for an invader.
It would be, unless the invader has a mechanism to hijack the security guards.
Oh, wow.
The polio virus has specific receptors that allow it to bind to and enter these immune tissues.
So instead of being destroyed.
Instead of being destroyed, it uses the rich cellular environment of the lymphoid tissue as a massive replication factory.
It takes the very structures designed to protect you and turns them against you.
Multiplying its numbers exponentially, yes.
It's a Trojan horse. It hides inside the security apparatus to build its army.
That's a great way to put it.
And once it reaches a critical mass in those lymph tissues, where does it go?
The dam breaks, and the virus spills over into the bloodstream. We call this phase viremia.
Okay, viremia, virus in the blood.
Now, the virus is no longer localized to the digestive tract. It is on the systemic highway. It is circulating throughout the entire body.
But for the vast majority of people, those 200 silent infections, this is where the story ends, right?
Fortunately, yes.
Because the immune system catches up, realizes there's a massive threat in the blood, and clears it out.
In 95% of cases, the immune system rallies, produces antibodies, neutralizes the virus in the blood, and the person clears the infection without ever knowing it happened.
But in a very small fraction of people.
In that small fraction, the virus manages to execute the final, devastating phase of its journey. It crosses the blood-brain barrier.
It gets off the highway and breaches the absolute most protected fortress in the human body, the central nervous system.
The exact mechanism of how it crosses the blood-brain barrier is actually still a subject of complex virological study.
Really?
Yes, but once it is inside the central nervous system, its behavior becomes terrifyingly specific.
It doesn't just attack random brain tissue.
No, it seeks out and binds specifically to motor neurons. And its primary target is a very specific structure in the spinal cord called the anterior horn cells.
The anterior horn cells. Why are those so critical? What makes their destruction result in paralysis?
Well, we have to look at the architecture of human movement. When you decide to move your leg, a signal originates in the motor cortex of your brain.
Right.
That signal travels down the thick bundles of nerves in your spinal cord, but that spinal cord nerve doesn't connect directly to your leg muscle.
There's a relay station.
Exactly. The anterior horn cell is that crucial relay station. It sits in the front portion, the anterior horn of the spinal cord.
Okay, I'm following.
It receives the command from the brain, and it fires the final peripheral nerve that actually connects to and stimulates the muscle fiber.
I see. So if the brain is the computer generating the command to print, and the muscle in your leg is the printer waiting for the data,
Yes.
the anterior horn cell is the connecting cable.
That is an excellent way to visualize it. The poliovirus enters the anterior horn cell, hijacks its internal machinery to replicate more virus.
And in the process,
Completely destroys the cell. It lyses or bursts open. The cell dies.
so the muscle itself is perfectly healthy.
Entirely.
It has blood flow, it has energy, and the brain is perfectly healthy. It's still sending the move command.
Yes.
But because the virus severed that connecting cable, the signal simply stops at the spinal cord. The muscle never receives the instruction.
And the tragic downstream effect is that a muscle that never receives a signal will never contract.
It just sits there.
Over time, through sheer disuse, that functionally paralyzed muscle will atrophy.
Right.
It will shrink and waste away, leading to the characteristic withered limbs we associate with polio survivors.
It's just a profound mechanical failure caused by this microscopic hijacker.
It really is.
And the timeline of this is bizarre because there's a delay. The child ingests the virus, it replicates in the gut, hits the blood, and then days later crosses into the nervous system.
Yes, there is a distinct lag.
So what does all of this internal warfare actually look like from the outside? If I'm a parent or a doctor, what is the clinical spectrum of this disease?
We have to view this as a spectrum of severity, keeping our iceberg in mind.
The 200-to-1 ratio.
Right. As we established, 95% of cases are completely asymptomatic. The immune system wins early.
But what about the next tier?
The next tier is what the medical literature calls abortive polio, or nonspecific polio. This accounts for roughly 5 to 10% of infected individuals.
Let's look at the symptoms listed for abortive polio.
Okay.
Fever, malaise, anorexia, which in this context just means a total loss of appetite.
Correct.
Nausea, vomiting, headache, pharyngitis, which is a sore throat.
From a diagnostic perspective, what does that list of symptoms look like to you?
It looks like literally every generic stomach bug or mild flu a toddler has ever brought home from daycare.
Exactly.
A parent sees a kid with a fever who threw up their lunch and doesn't want to play. They think, we'll do fluids and bed rest.
Nobody looks at that and thinks, my child's motor neurons are about to be attacked.
Not a chance.
And that is the terrifying brilliance of the virus. Even when it does cause symptoms, the disguise is flawless.
Wow.
The immune system is fighting the viremia, the virus in the blood, and the resulting systemic inflammation just causes generic, nonspecific illness.
So the virus is aborted by the immune system before it reaches the nervous system.
Yes.
But if the immune system doesn't stop it there, we move down the spectrum to non-paralytic polio.
In non-paralytic polio, the patient experiences that same generic flu-like illness, but with the addition of signs of meningeal irritation.
Meningeal meaning the meninges, the protective membranes wrapping around the brain and spinal cord.
Correct.
So the virus has breached the central nervous system and the lining is getting inflamed.
Yes. The clinical signs of this are a stiff neck, stiffness in the back, perhaps sensitivity to light.
Okay.
The virus is in the central nervous system, but it hasn't yet caused permanent, widespread destruction of the anterior horn cells.
So the patient is deeply uncomfortable, but they are not paralyzed.
Not yet.
But then We reach the absolute bottom of the spectrum, the rare 0.1% of cases where the virus fully executes its devastating potential. Paralytic polio.
This is the outcome we all fear.
And the sources break this down into 3 distinct types. Let's start with the most common of these severe outcomes: spinal paralytic polio.
The onset of spinal paralytic polio is often described as a biphasic illness, meaning it hits the patient in 2 completely distinct waves.
Walk us through that timeline, because it sounds like a cruel psychological trick.
It is. The first phase is essentially the abortive polio we just discussed. The child gets a fever, a headache, maybe vomits.
So the parents are dealing with that.
They feel unwell for a few days, but then the fever breaks. The symptoms subside. For 2 to 3 days, the child appears to be making a full normal recovery.
So the parents think they're out of the woods. The bug has passed.
It is a false dawn. That period of apparent recovery is merely the systemic viremia subsiding, while the virus silently crosses the blood-brain barrier and begins its targeted assault on the spinal cord.
So it's regrouping.
After those 2 or 3 days, the second phase hits with absolute brutality.
What happened?
The fever returns, often much higher, the headache is severe, and they develop intense, agonizing muscle pain.
The muscles are hurting because the nerve cells controlling them are actively dying.
Yes. And when a doctor examines the patient during the second phase, the clinical presentation of the paralysis is very specific.
What is the hallmark sign?
It is asymmetric flaccid paralysis.
Let's define those terms clearly. Start with asymmetric.
Asymmetric means the paralysis does not mirror itself on both sides of the body. The virus destroys anterior horn cells randomly.
So a child might lose total function in their left leg, while their right leg retains normal strength.
Exactly. Or perhaps their right arm and left leg are affected. It is completely chaotic.
And flaccid.
Flaccid describes the tone of the paralyzed muscle. In some neurological diseases, a severed connection causes the muscle to spasm uncontrollably, becoming rigid or spastic.
Right.
But in polio, because the anterior horn cell, the final command node, is dead, the muscle receives absolute zero input.
It just goes offline.
It becomes completely limp, floppy, and devoid of any resting tone. It is flaccid.
The outline notes that this flaccid paralysis is usually worse in the proximal muscles than in the distal muscles.
Generally, yes.
Meaning the muscles closer to the core of your body, your thighs, your hips, your shoulders, are hit harder than your hands or your feet.
That's right. And the progression happens rapidly over a few days. Interestingly, there is a very brief window at the very onset of the neurological attack where a doctor might find increased deep tendon reflexes.
Like when they tap your knee with a rubber hammer, the leg kicks out harder than normal.
Exactly. That hyperreflexivity is the nerve cell firing erratically as it is being inflamed and destroyed by the virus.
Like a short circuit.
Yes, but it is a very short-lived phenomenon. Once those anterior horn cells actually lyse and die, the reflexes vanish completely.
And you transition rapidly to what the sources call absent deep tendon reflexes and paresis, which is severe muscular weakness.
Correct.
And this weakness isn't just in the arms and legs. It can hit the neck, the abdomen, the trunk, the thorax.
It can paralyze the diaphragm.
Meaning the patient suddenly cannot pull air into their lungs.
Yes, which is life-threatening.
And the sources note that lower limb paralysis is frequently accompanied by bowel and bladder dysfunction.
The nerves controlling the sphincter muscles and the bladder wall originate in the lower spinal cord.
So they get caught in the crossfire.
When those surrounding areas are devastated by the virus, the patient loses the ability to voluntarily urinate or defecate.
But here's the detail that is truly haunting. Through all of this, the asymmetric paralysis, the floppy limbs, the inability to breathe or go to the bathroom sensation remains entirely intact.
That is the cruelest aspect of the pathophysiology.
It's hard to even imagine.
Polio is a highly specialized virus. It targets motor neurons almost exclusively. It largely ignores the sensory neurons, which run on parallel but distinct pathways in the spinal cord.
So the child cannot move their leg, but they can feel a needle prick.
They feel everything.
They feel the agonizing pain of the muscle inflammation. They feel the bed sheets against their skin. The sensory dashboard is fully lit up, but the steering wheel is completely disconnected.
They're fully aware, fully feeling, but entirely trapped.
Wow.
Now, a crucial question arises here.
Yeah?
If everyone gets the same virus, why do 95% of people clear it silently, while 0.1% progress to this catastrophic paralysis?
That is the big question. And our sources detail specific risk factors that can tip the scales. Let's look at these because some of them seem totally bizarre.
Let's do it.
First, immunodeficiency. Conditions like HIV or specific genetic issues like B-cell dysfunction or IgA deficiency, let's explain those.
The immune system is complex. B cells are the white blood cells responsible for manufacturing antibodies, the targeted weapons that neutralize the virus.
So if you have B-cell dysfunction, your body literally cannot print the weapons needed to fight the viremia.
Exactly. And IgA, or immunoglobulin A, is a very specific type of antibody that guards your mucous membranes,
Including the lining of your gut.
yes.
So if you have an IgA deficiency, the virus doesn't even face resistance when it lands on the gut lining. It just walks right in.
That's precisely what happens.
That makes perfect sense.
Yeah.
The outline also lists pregnancy, which we know suppresses the immune system so the body doesn't reject the fetus, creating a window of vulnerability.
Right.
But then we get to the strange ones. Tonsillectomy, intramuscular injections, and strenuous exercise.
I know they sound unrelated.
Why on earth would getting your tonsils out or playing a hard game of soccer make a stomach virus paralyze you?
It seems baffling until you view it through the lens of the pathophysiology we just discussed. Let's take the tonsillectomy first. What are the tonsils?
They are lymphoid tissue, the exact same kind of tissue as the Peyer's patches in the gut.
Yeah.
They are the security checkpoints in the throat.
Exactly. If a child has recently had their tonsils surgically removed, they have raw healing tissue in the exact anatomical location where the virus first begins to replicate.
Oh, I see.
You have effectively removed the guards and left an open, highly vascularized wound that provides the virus with a massive, unimpeded on-ramp directly into the bloodstream.
You accelerate the viremia.
Yes, significantly.
Wow. Okay, what about strenuous exercise? How does running around trigger paralysis?
Consider the viremia phase. The virus is circulating in the blood. If you engage in heavy, strenuous exercise, what happens to your physiology?
Your heart rate spikes, and massive volumes of blood are pumped outward from your core directly into your large skeletal muscles to provide oxygen.
So if your blood is full of the polio virus, you are using your own cardiovascular system to forcefully pump massive concentrations of the virus directly to the muscles and the delicate motor nerve endings that serve them.
You are literally physically delivering the payload to the target.
You are. As for intramuscular injections, a routine vaccine shot in the shoulder or thigh, the trauma of a needle piercing the muscle tissue creates a microscopic zone of injury and localized inflammation.
And inflammation brings increased blood flow and immune activity to that specific spot.
Yes. And if the virus is already in the blood, that localized inflammation can act almost like a beacon,
Drawing the virus in.
drawing the virus to those specific motor nerve endings, or potentially providing an open pathway for retrograde transport.
What's retrograde transport?
It's where the virus travels backward up the nerve axon directly into the spinal cord.
It is deeply unsettling to realize that the mundane activities of childhood, getting a shot, running outside, getting your tonsils out, could be the exact mechanical triggers that turn a silent infection into a lifelong disability.
It highlights how precarious the balance is.
Now, spinal polio is devastating, but the sources outline two other forms that are even more dangerous. Tell me about bulbar polio.
Bulbar polio occurs when the virus ascends even higher. Instead of just attacking the spinal cord, it breaches the brainstem.
Specifically targeting the medulla oblongata and the cranial nerves.
Yes.
The medulla is basically the central processing unit for staying alive, right? It's the evolutionary autopilot.
It controls the autonomic functions you don't think about. Your heart rate, your blood pressure, your respiratory rhythm.
And the cranial nerves.
The cranial nerves that originate near there control the intricate mechanics of your face, throat, and swallowing.
The clinical presentation detailed here sounds like an absolute nightmare. When the cranial nerves fail, the patient loses the ability to swallow, but they are still producing saliva.
Yes. Because they cannot swallow, saliva continuously pools and accumulates in the pharynx. Furthermore, the nerves controlling the vocal cords and the cough reflex are paralyzed.
So you have a patient who is fully conscious, feeling everything, who is quite literally slowly drowning in their own secretions because they physically cannot swallow them or cough them up.
It is horrific to witness.
The sources mention nasal regurgitation of fluids. If they try to take a sip of water, the paralyzed muscles in the throat can't route it to the stomach, so it just spills back out through the nose.
And as the virus penetrates deeper into the medullary centers, the autonomic nervous system begins to collapse.
What does that look like?
You see severe respiratory difficulty, not just because the diaphragm might be weak, but because the brain's metronome for breathing becomes erratic. The respiration loses its rhythm and depth.
The outline also mentions cardiovascular alterations, like alternating flushing and modeling of the skin.
The medulla controls the constriction and dilation of blood vessels. When it fails, blood pressure wildly fluctuates.
So the autonomic system is in total disarray.
Total disarray. Bulbar polio has a terrifyingly high mortality rate without immediate intensive life support.
And the final, rarest form of paralytic polio mentioned is polioencephalitis, sometimes called bulbospital polio. This is when the virus pushes past the brainstem and invades the higher cognitive centers of the brain itself.
The symptoms here transition from flaccid paralysis to profound neurological chaos.
Like what?
Patients present with seizures, severe disorientation, and marked irritability. Interestingly, you may see spastic paralysis and hyperreflexia here.
Rigid, spasming muscles. I thought polio caused flaccid paralysis.
It usually does, but here, because the brain's upper motor neurons, which normally suppress spasms, are being destroyed, the muscles can become spastic.
That's awful. The patient becomes drowsy, they develop coarse tremors, and ultimately it leads to coma and death. It's the absolute extreme of the virus's potential.
Yes, it is the most severe presentation.
Now, before we move away from clinical features, there is one more item in this section of the source material that we have to discuss with extreme care and absolute objectivity.
I know what you're referring to, VAPP.
Yes, vaccine-associated polio paralysis.
It is a complex and highly sensitive reality of public health.
It is. VAPP is clinically suspected if a patient develops paralytic disease within a very specific window, 7 to 14 days after receiving the OPV, the oral polio vaccine.
Particularly in regions where the wild polio virus has already been eradicated.
The obvious glaring question for anyone listening is, how does the medicine designed to wipe out polio actually end up causing it?
To understand this, we must look at the mechanics of the OPV itself. The oral polio vaccine is a live attenuated vaccine.
Meaning?
This means the drops administered into the child's mouth contain actual living polio virus. However, the virus has been attenuated.
Which means it has been repeatedly grown under suboptimal conditions in a laboratory to intentionally introduce genetic mutations that weaken it.
Yes.
It's like a sparring partner for the immune system.
Yeah.
It looks and acts enough like the wild virus to trigger the body to produce lifelong antibodies, but is wearing heavy padded gloves.
Exactly. It is theoretically too weak to cross the blood-brain barrier and cause paralysis.
Right. It replicates in the gut, triggers the immune response, and is shed in the feces.
Which actually helps passively immunize other people in the community who might come into contact with it. It is a brilliant tool.
But biology is inherently messy. Because it is an RNA virus actively replicating in the human gut, it is constantly making copies of its genetic code.
And every time it copies itself, there is a chance for a typo, a mutation.
Yeah.
In an infinitesimally small number of cases, the statistics suggest roughly 1 in 2.7 million doses administered. Those random mutations happen to perfectly reverse the genetic changes made in the lab.
Oh, no.
The virus essentially reverts to its neurovirulent form. It takes off the padded gloves.
And when that extremely rare genetic reversion happens, the vaccine strain of the virus crosses the blood-brain barrier and attacks the anterior horn cells,
causing the exact asymmetric flaccid paralysis it was designed to prevent.
It can paralyze the vaccinated child within that 7 to 14-day window.
Or if the reverted virus is shed into an unvaccinated community, it can circulate and paralyze others. This is known as CVD-PV, circulating vaccine-derived poliovirus.
Let's contextualize this, because this is the brutal utilitarian calculus of global public health.
It is a very difficult calculation.
The OPV is incredibly cheap, pennies a dose. It's incredibly easy to administer. You don't need a trained nurse with sterile needles. A volunteer can just put 2 drops in a child's mouth.
And it builds mucosal immunity in the gut, which stops transmission dead.
Right. It is the perfect weapon for mass eradication.
But the cost of utilizing that perfect weapon, the cost of saving hundreds of thousands of children from the wild virus every single year, is the heartbreaking statistical certainty that a tiny, tiny fraction will be paralyzed by the tool itself.
Public health officials had to weigh the millions saved against the handful lost. It is a heavy burden.
It really is. It's a sobering reality.
So, if a doctor is looking at a patient who presents with asymmetric flaccid paralysis, whether from wild polio or VAPP, how do they definitively confirm what they are looking at?
They need laboratory confirmation.
And more importantly, once the damage is done, what can modern medicine actually do for that patient? Let's transition into the diagnosis and treatment protocols.
Diagnosis begins, as always, with acute clinical suspicion. Any presentation of sudden floppy paralysis in a child, especially if it is asymmetrical, must be treated as polio until proven otherwise.
But you cannot base a global eradication campaign on clinical guesswork. You need definitive, laboratory-confirmed proof.
And the sources are very clear. Stool culture is the gold standard for confirmation.
Because, as we know, the virus replicates heavily in the gut and is shed in the feces. But the protocol for getting this stool culture is intensely rigorous. You don't just take a quick swab in the emergency room.
No, the WHO protocol demands precision to avoid false negatives. First, you must collect 2 separate stool specimens, and they must be collected at least 24 hours apart.
Why wait 24 hours? Why not just take 2 samples right then and there?
Because the shedding of the virus in the gastrointestinal tract is not a constant uniform stream, it can be intermittent.
Oh, I see.
By spacing the samples out over 24 hours, you significantly increase the statistical probability of capturing the virus if it is present.
Furthermore, the samples must be collected within 14 days of the onset of symptoms.
That is the critical window where viral shedding is at its absolute peak.
If you test a month later,
The immune system may have cleared the virus from the gut, even though the neurological damage is already done, leading to a false negative.
and the physical amount required is specific. The sources say the specimen must be the size of an adult thumb, which translates to roughly 8 to 10 grams of material.
But getting the sample is the easy part.
Right, the real challenge is what happens next. The outline details a logistical protocol known as the reverse cold chain.
This is one of the most remarkable and fragile logistical feats in global medicine.
Explain the concept of the cold chain first.
A standard cold chain is how we distribute vaccines. You start at a massive central manufacturing laboratory where the vaccine is frozen. You move it to regional refrigerated hubs, then to district freezers. Finally, it goes into a small cooler box carried by a health worker to a remote, hot, rural village. The entire goal is to keep the delicate vaccine cold as it moves from the center to the periphery.
But to test this stool sample, you have to do the exact opposite.
Precisely. The RNA virus in that stool sample is highly sensitive to heat and will degrade rapidly.
Okay.
So you have a rural health worker in a small clinic, perhaps with no reliable electricity, who has just collected an adult thumb-sized sample from a paralyzed child.
They must place it in a clean container with an external screw-on cap to ensure absolutely no leakage.
Yes. They must meticulously label it with a water-resistant pen name, ID number, specimen number, and date.
And then the clock starts.
That sample must reach a sophisticated WHO-accredited viral laboratory within 72 hours.
3 days.
And for every second of those 3 days, it must be maintained at freezing temperatures.
I want you listening to really imagine the reality of this. Let's use Nigeria as the example, since it's deeply referenced in our sources. The accredited labs are in cities like Maiduguri and Ibadan.
Think about the distance.
Imagine a health worker in a remote village in the deep north. They pack this tiny screw cap container into a cooler packed with ice. They might have to carry it on foot to a dirt road.
Wait for a motorbike taxi.
Ride for hours through 100-degree heat to reach a regional bus station. Put the cooler on a crowded bus heading south, constantly checking to see if the ice is melting.
If the bus breaks down, the sample warms up, the RNA degrades, and the test is completely useless.
It is a high-stakes relay race against thermodynamics.
And it requires a seamless chain of communication, reliable transport, and constant access to fresh ice across hundreds of miles of challenging terrain just to confirm one single data point on an epidemiological map.
And the truly heartbreaking part of this incredible logistical effort to diagnose the disease is what comes after.
Yes.
Because the treatment protocols listed in the sources are strictly palliative.
Palliative care means the medical interventions are focused entirely on managing symptoms, providing comfort, and preventing secondary complications.
Right.
There is no antiviral medication that can stop the polio virus once it reaches the central nervous system. There is no surgery that can repair a lion's anterior horn cell.
The damage is permanent. The treatments listed here are visceral and highly invasive. It starts with absolute bed rest. Analgesics and hot packs are applied to manage the agonizing muscle pain during the acute inflammatory phase.
If the patient has bulbar polio and the medulla is failing, medical intervention escalates to mechanical ventilation.
The patient must be intubated and placed on a machine to force air into their lungs because their brain has forgotten how to command the diaphragm.
And for the spinal polio patients suffering from severe asymmetric paralysis, the supportive care becomes a grueling daily reality.
Because they cannot move themselves.
Right. Nurses or caregivers must manually mobilize them, turning their bodies every few hours, day and night, to prevent the formation of decubitus ulcers, or severe bed sores, which can easily become infected and fatal.
We also discussed the autonomic failure of the bowel and bladder. The gastrointestinal tract loses its motility. The bladder muscle cannot contract.
The interventions for this are deeply humbling. High-fiber diets and laxatives, yes, but often it requires manual fecal evacuation.
Wow.
The bladder requires catheterization, or a process called manual bladder compression, where a caregiver must physically press down heavily on the patient's lower abdomen to forcefully squeeze the urine out of the paralyzed bladder.
It strips away all physical autonomy. You described it earlier as the trapped pilot scenario, and that is medically accurate. The sensory neurons are untouched.
The patient feels the catheter being inserted. They feel the manual evacuation. They feel the indignity and the terror of being entirely dependent on another human being for their most basic biological functions.
Which is why the sources explicitly include long-term psychological management alongside convalescent physiotherapy as core components of recovery.
It's vital.
You aren't just trying to physically stretch the atrophied muscles to prevent permanent contractures. You are trying to help a human mind adapt to a body that has suddenly and violently betrayed them.
When you look at the immense suffering caused by the disease and the absolute lack of any curative treatment, it drives home a singular, undeniable conclusion for public health officials.
You cannot treat your way out of a polio outbreak.
The only ethical and practical response is absolute prevention.
You have to stop the virus before it ever enters the mouth. Which brings us to the most monumental part of this story, the global war, the Global Polio Eradication Initiative, or the GPEI.
To understand the necessity of the GPEI, we have to look at the sheer burden of the disease before 1988. We established the iceberg ratio. 1 in 200 infections results in paralysis.
Right.
That means to see hundreds of thousands of paralyzed children, the virus must be infecting tens of millions of people annually.
The numbers in our source material are staggering. In 1988, when the GBEI was officially launched at the 41st World Health Assembly, there were an estimated 350,000 cases of paralytic polio occurring globally every single year.
That is nearly 1,000 children paralyzed every single day.
Unbelievable.
The Assembly, comprising 166 member states, realized this required an unprecedented coalition. It was spearheaded by the World Health Organization.
But crucially supported by UNICEF, the U.S. Centers for Disease Control and Prevention, and Rotary Club International.
Rotary Club mobilized incredible grassroots funding and an army of on-the-ground volunteers.
And the results of that coalition are arguably one of the greatest triumphs in human history. By 2010, the estimated 350,000 cases had plummeted to just 1,349 reported cases.
That is a reduction of more than 99%.
The human impact of that statistic is profound. The GPEI estimates that their efforts have spared over 8 million people from the lifelong crippling effects of polio.
And beyond the medical triumph, there is a massive socioeconomic victory. By preventing millions of debilitating cases, the initiative has actively reduced poverty.
Because individuals with severe physical disabilities in developing nations face nearly insurmountable barriers to education, employment, and self-sufficiency.
Exactly.
The scale of the intervention is mind-numbing. The sources note that over 2 billion children worldwide have been immunized during supplementary immunization days.
But as anyone who works in public health knows, taking a disease from 350,000 down to 1,000 is hard. Taking it from 1,000 down to absolute zero is agonizing.
The last 1% is always the most difficult, because the virus retreats to the most complex, inaccessible, and fragile corners of the globe. By 2011, the sources indicate there were only 4 countries remaining that were considered polio endemic.
Meaning the wild virus had never been fully interrupted and was still circulating naturally.
The acronym used is PAIN: Pakistan, Afghanistan, India, and Nigeria.
The persistent pockets were incredibly localized. The northern states of Nigeria, and the porous, often conflict-ridden border region between Afghanistan and Pakistan.
But the reality of virology is that lines on a map mean nothing. Just because it is endemic in only 4 countries does not mean the rest of the globe is safe.
No, it doesn't.
The sources list a litany of countries that experienced imported cases: China, Liberia, Congo, Mali, Cote d'Ivoire, Mauritania, Gabon, Guinea, Nepal, Niger, Kenya.
Let's explore how an imported case happens.
Okay.
If you have a polio-free country, let's say Mali, but their routine immunization rates have started to slip because they think the threat is gone, Suddenly, a merchant or family travels from endemic northern Nigeria into Mali.
They might feel perfectly healthy. They're one of the 200 asymptomatic carriers.
They cross the border, they use a local restroom, they shake hands, and they shed the virus into a new, susceptible environment.
The iceberg has been successfully transplanted.
The virus finds new hosts, replicates, and weeks later, a child in Mali is paralyzed by a virus that originated 1,000 miles away.
This is why the GPEI's objectives couldn't just be give vaccines in endemic areas.
Right.
The objectives listed in the outline are layered. Interrupt wild polio transmission globally, achieve strict certification of eradication, and crucially, use the polio campaign to build broader health systems.
Strengthening routine immunization and disease surveillance for all communicable diseases.
To achieve these objectives, the GPEI employed 4 primary strategies. The first is routine immunization, ensuring every infant receives their polio drops as part of their standard pediatric care.
But routine care isn't enough to stop an outbreak, which brings us to the second strategy, supplementary immunization, specifically National Immunization Days, or NIDs.
NIDs are a spectacle of public health.
They really are.
The goal is to vaccinate every single child under the age of 5 in an entire country over the course of just a few days, regardless of their prior vaccination status.
You literally flood the entire population with the attenuated vaccine simultaneously, denying the wild virus any susceptible host to jump to.
The third strategy is the detective work, AFP surveillance, acute flaccid paralysis surveillance.
We talked about this. You mandate that every doctor, nurse, and community healer report any child whose limbs suddenly go floppy. You assume it's polio, you trigger the reverse cold chain, and you test the stool.
You cannot fight an invisible enemy without a radar system. AFP surveillance is the radar.
And when a blip appears on that radar, when a stool culture comes back positive for wild polio, you trigger the fourth and most intense strategy.
Mop-up immunization, or sub-NIDs.
Yes.
The analogy for mop-ups is fascinating. If polio is a massive forest fire, the National Immunization Days are like flying a fleet of tanker planes over the entire forest and dropping thousands of gallons of water. You successfully suppress the main conflagration.
But deep in the underbrush, there are still small, invisible embers smoldering. The AFP surveillance is the spotter in the tower looking for a wisp of smoke.
And when they spot it, a confirmed case in a specific village, the mop-up is the elite team of smoke jumpers.
You don't drop water on the whole forest again.
No. You deploy teams on foot, dropping them directly into that specific district. Within 48 hours, they go house to house, tent to tent, ensuring every single child in a tight radius gets 2 drops of vaccine.
You create a localized, impenetrable firewall around the ember so it cannot spread.
The logistics required to execute that are breathtaking. In 2009 alone, according to the data, these strategies resulted in the immunization of over 361 million children across 40 different countries during 273 separate, highly coordinated campaigns.
361 million kids opening their mouths for 2 drops.
And all of this is driving toward one goal: certification. The WHO doesn't just hand out a gold star.
No, a region is only certified polio-free if it meets 3 strict criteria.
3 continuous years of 0 wild polio cases. A disease surveillance system that meets international standards, proving you are actually looking for it. And the demonstrated capacity to detect and respond instantly to any imported cases.
Which brings us to a fundamental analytical question. In 1988, looking at all these diseases ravaging the globe, why did scientists look at poliomyelitis and say, we can actually do this, we can eradicate this?
We have only ever eradicated one human disease in history: smallpox. Why polio?
The source material lists the feasibility factors, the biological vulnerabilities of the virus, and the first one is the absolute linchpin.
There is no animal reservoir.
This is the biological Achilles heel of polio. The virus only possesses the molecular keys to enter human cells. It cannot infect dogs or birds or mosquitoes.
If a disease has an animal reservoir like rabies in bats or Ebola in primates, you can never truly eradicate it, because even if you vaccinate every human, the virus just hides in the jungle,
mutating and waiting for an opportunity to jump back.
But polio has nowhere to hide. If we deny it human hosts, it goes extinct.
Furthermore, the sources note there is no long-term carrier state. Unlike a disease like HIV, which hides in the body for decades, a person infected with polio either clears it or is paralyzed by it, but in either case, they stop shedding the virus in their feces after a few weeks.
Add to that the fact that permanent immunity is possible. The wild virus survives poorly in the open environment without a host, and we have a spectacularly effective, cheap, easy-to-administer tool in the OPV.
Biologically, eradication is entirely feasible. The virus is vulnerable.
But we aren't there yet. It's been decades since 1988. The challenges listed in the sources aren't really about the biology.
They are about human systems. The 200 silent infections make surveillance a nightmare. Similar diseases confuse the clinical picture, and the quality of immunization campaigns can be poor.
The systemic failures listed are profound. Inability to maintain the cold chain in extreme environments, severe lack of basic health infrastructure in developing regions,
And the most insurmountable barriers of all: insecurity, civil wars, and internal political strife.
You cannot execute a hyper-precise 48-hour mop-up campaign in a village that is currently an active war zone. You can't ask a health worker to carry a cooler of vaccines across a front line.
Which perfectly transitions us into the final and perhaps most illuminating section of our deep dive.
To truly understand why the GPEI has struggled in its final miles, we have to zoom in on a specific battleground. We must examine the story of Nigeria, the N in the PAIN acronym.
The Nigerian context is a profound case study in the collision of biology, sociology, and politics.
Let's look at the situation around the year 2000. The wild polio virus was actually largely interrupted in the southern and central parts of Nigeria. The campaigns were working.
But the virus stubbornly persisted in the deep north.
The sources outlined several roadblocks in the north. There was persistent low coverage during routine immunizations. The underlying health system architecture was incredibly weak, meaning access to care was sparse.
But the most critical barrier, the true stumbling block, was a crisis of trust.
The outline points specifically to the effect of rumors regarding vaccine side effects, which led to widespread community rejection. We have to look at this without judgment, completely objectively.
Put yourself in the shoes of a parent in a remote northern community.
You are marginalized from the central government. Your local clinic rarely has basic antibiotics or clean water.
And suddenly, government trucks roll in, accompanied by international foreigners, forcefully insisting that your perfectly healthy child must swallow these mysterious drops to protect against a disease you rarely see in its paralytic form.
And into that environment of suspicion, rumors are introduced. Rumors that the vaccine is unsafe, that it contains contaminants, or that it is a Western plot designed to sterilize children or spread HIV.
If you're a loving parent and you hear these rumors from your neighbors, your protective instinct dictates that you hide your child when the vaccination teams arrive.
It is a rational response to perceived threat based on the information provided by your community.
But the biological consequence of that sociological breakdown was catastrophic. Because communities rejected the vaccine, massive pockets of the population remained susceptible.
The virus thrived in these northern safe havens.
And it didn't stay there. The sources note that this unvaccinated reservoir caused the virus to repeatedly spill over.
It reinfected the polio-free states in the south of Nigeria. And even worse, it spilled across international borders, reinfecting neighboring countries that had fought hard to become polio-free.
Nigeria inadvertently became a net exporter of the wild polio virus, entirely due to a localized breakdown in community trust.
So how does the government solve that? If the science is perfect, the OPV works, but the people reject the science, a harder push with more science won't work.
In 2009, the Nigerian federal government realized they had to pivot. They established an emergency task force involving the northern governors. They tried to flex political muscle.
But even political muscle has limits if the politicians are not trusted at the grassroots level. The true turning point, the watershed moment detailed in our sources, occurred in mid-2009.
The intervention of the Sultan of Sokoto.
Yes, the Sultan of Sokoto is one of the most revered, spiritual, and traditional leaders for Muslims in Nigeria. He established a national task team composed entirely of northern traditional leaders and clerics.
This is a masterstroke of public health strategy. The WHO and the federal government stepped back, and they let the trusted voices of the community step forward.
When the Sultan and the traditional leaders publicly endorsed the OPV, when they assured their congregations that the vaccine was safe, halal, and necessary to protect their children, the entire paradigm shifted.
The medical intervention was translated into a cultural mandate. It became a community standard to participate.
And the results were staggering. By the end of that same year, 2009, this cultural and political shift resulted in immunization coverage skyrocketing to 50% in previously resistant areas.
It proves that the OPV is only half the cure. The other half is the Sultan of Sokoto.
But the Nigerian story also highlights the systemic failures that continue to plague eradication efforts globally. The sources list management issues, constant funding shortfalls, and the persistent fragility of community perception regarding vaccine safety.
Trust is not a one-time achievement. It must be continuously maintained. And that trust is intimately tied to the physical realities of the logistics network.
We return to the cold chain.
The extreme heat. Think about the mechanical fragility here. Let's say a traditional leader has finally convinced a hesitant mother to bring her child for the vaccine.
The mother overcomes her fear, but the health worker's cooler box has been sitting in the 105-degree sun for 6 hours because their transport broke down.
The ice is melted. The RNA in the vaccine has degraded.
The health worker, perhaps unaware or under pressure to hit quotas, administers the warm, useless drops to the child.
The child receives no immunity. A month later, the wild virus sweeps through and that child is paralyzed. What happens to the community trust then?
The mother says, "I listened to the leaders. I took the drops. And my child was paralyzed anyway. The vaccine is a lie."
A single mechanical failure in a $2 cooler box can unravel years of sociological progress and instantly validate the most paranoid rumors.
Eradication demands perfection across every single vector: virology, temperature control, funding, and human psychology. It is an incredibly delicate web.
It really is the ultimate high-wire act.
And that brings us to the end of our journey today. We have covered an immense amount of ground. We started by examining a tiny, durable strand of Plicornaviridae RNA, a virus perfectly evolved to slip silently through the phaco-oral route.
We tracked its insidious pathophysiology, hiding in the Peyer's patches, surging through the bloodstream, and executing a highly specific, devastating assassination of the anterior horn cells in the spinal cord, severing the vital connection between the brain and the muscle.
We look at the harrowing clinical reality, from the cruel biphasic trick of spinal polio to the terrifying autonomic collapse of bulbar polio. We discuss the absolute indignity and psychological toll of the palliative care required, the mechanical ventilators, the manual bodily evacuations.
And we zoomed out to witness the majesty and the extreme difficulty of the global polio eradication initiative. We saw how a coalition of nations drove the numbers from 350,000 paralyzed children a year down to just a few dozen, utilizing immense strategies like mop-ups and AFP surveillance.
And finally, through the lens of Nigeria, we learned the most important lesson of all: that wiping a disease off the face of the earth requires traditional leadership, cultural empathy, and unbreakable community trust, just as much as it requires a laboratory. So having unpacked all of this, how do we synthesize it? What is the core takeaway here?
The fight against polio is perhaps the greatest mirror we have for human cooperation. It teaches us that public health is never just biology. You cannot cure a population purely with a microscope.
Is it true?
Eradicating a pathogen requires a symphony of flawless logistics, uninterrupted financial commitment, and most crucially, the delicate art of human ecology. We are fighting a biological enemy, but our most significant obstacles and our greatest tools are entirely human.
And that leaves you, the listener, with a final provocative thought to mull over. The entire premise of polio eradication, the billions of dollars, the decades of effort, relies heavily on one specific biological vulnerability. Humans are the only reservoir. The virus has nowhere else to hide. But our world is fundamentally changing. Ecosystems are shifting, permafrost is melting, and viruses are constantly mutating to survive. What happens to our grand global health initiatives if a changing climate or a random genetic drift suddenly allows an eradicated disease to find a new host, a new hiding place in nature?
It's a sobering thought.
If we push a disease to the absolute brink, 99.9% eradicated, does our own human complacency, our collective sigh of relief, become the greatest risk factor of all? It's something to keep in mind the next time you read a headline declaring total victory over nature. Thank you for joining us on this deep dive. Keep questioning the surface, keep exploring the mechanics, and we will catch you on the next one.